Okay. All right. Welcome, everybody. We are hosts today at MoveMend Rehab and Performance. I'm Dr. Mika Riley here, and we have the pleasure of talking to Dr. Grant Garcia, based out of Seattle, Washington, and we're going to go over all things ACL. So it's a pleasure having you, Dr. Garcia. If you don't mind telling us a little bit about you and your history and everything, and then we'll go from there.
Awesome. Well, first off, thanks for having me. I'm really excited about this. This will be fun. Be a good conversation. I love talking about ACLs. It was a busy ACL season last year. It's still busy in the summer. So this is a hot topic near and dear to my heart. So I'm originally from Mercer Island. My wife and I both were from Mercer Island, and then moved to the East Coast for all my training. So I trained at Penn and went to Brown for undergrad, Penn for med school. Hospital special surgery, we did a ton of athletes. So that was really where kind of the high level orthopedics happened in New York, taking care of, Giants, Mets, Knicks, you name it. It's awesome. 8 sports teams there. And then fellowship at Rush with Brian Cole and a lot of the other guys there as well in Chicago. So we did the Bulls and the White Sox. And we really got that's where the high level ACL cartilage sort of knee stuff came from. And then fortunate enough to come back here, mostly myself, but also a lot of my wife's staying here. So one place you can practice is in Seattle. So I'm really happy. And ever since, it's been awesome. It's an amazing experience to practice here and be a part of Orthopedic Specialists of Seattle, and getting to do all sort of interesting things and meeting so many good people. And the Seattle patients are the best by far. I've practiced many places and they are the best. It is awesome.
Yeah, there's something about us Seattleites.
Yeah, they're all active. They all want to get back, and they're really motivated, and they're very understanding.
Yeah. Okay, so let's get into it. I think, there's some people out there that don't even know what the ACL is. I think it's a good thing to just probably start there. Give us the whole spiel on what the ACL is and how it works.
Sure. So inside your knee, you got 2 ligaments, and it's kind of good. We'll do a little cross like this. You have an ACL and you have a PCL. So the ACL is also known as the anterior cruciate ligament. That is the number 1 ligament you hear about. That's the one that's all the athletes tear. If you look at the number of things I treat, and I do a lot of different surgeries and craziness, the ACL is by far the most common. And amazingly, if you have MCL, you have LCL, you have PCL. So you have 4 ligaments, 2 on the inside, 2 on more the outside of the knee. The ACL is far outweighs the others. And that's what helps your knee from going forward. But really the most important thing is it's just more commonly torn in any type of contact sports. And so we don't have to go into too much detail, but usually, when it's torn, the blood supply is not great. And so that's when you talk about other things. And it's a very important ligament. It's interesting because if you tear your PCL without your ACL being injured, you can get away without surgery more frequently, as you might know. But if you tear your ACL, we'll get into sort of the COPR, non-COPR, and everybody's different philosophies. And it's good we have an expert PT on here, so this will be good to talk about. But, it's a lot more important ligament, and it tends to need surgery much more frequently. So as an orthopedic surgeon, I obviously see more of those than I do of the other things, from not only the commonality of it, but the actual desire, the need to be fixed. So hopefully that was helpful.
Yeah. So when you get someone in your office, you see someone in the clinic, what's the process about deciding what the next steps are?
Yes.
Where they go,
so,
CT, MRI, what is your process?
So I will say with the caveat that I am a referral source for ACL injuries. So it is not fair for me to tell you exactly what every patient would get normally if they went into a random doctor's office. A lot of patients are referred to me directly for an ACL injury and directly for ACL surgery. So I have a bias on what I see. But usually someone comes in, I saw 2 patients today. They came in, they felt a pop. They had I diagnosed with an ACL tear. It depends on the patient whether I drop that information right away or whether we get the MRI to confirm it, just because you want to make sure that's correct. Because everyone always thinks that as doctors, we have magic hands and we can figure out exactly what's wrong with the patient. But as a really good team physician once told me, he's like, I said, what in the field? Well, how do you know exactly what's going on? He said, to be honest with you, we kind of go through the motions. We think we know what's going on, but really it's that MRI that gives us the information. So we were good diagnosticians, but it's hard when someone's in pain, as you've seen in your office, to get a good exam. So we try to give them as much information as possible. Always acute ACL PT to start. Prehab, whatever way you want to talk about it. it's really important. And that's why it's essential to have good teammates like you guys working with us. And then the next step is pretty much always an MRI because, and we don't want to go too much into this unless this is your next question, but a lot of times they're associated with other things. And so we want to not only confirm the ACL, we want to confirm, are there other concomitant injuries that are maybe involved?
Yeah. And what are the typical common injuries involved with an ACL?
So the most common injuries usually are the MCL, which the nice thing about the MCL, the reason you don't hear about it a lot is it's very, very commonly treated without surgery. And so a lot of times it'll scar on its own, or even a grade 1 injury is very hard to diagnose, especially if they had an ACL injury. So it happens frequently, but the number of surgeries you need to do is, almost 0 to, that low 5 percentile. Medial meniscus tears are very common with sort of acute injuries, and the lateral meniscus tears are more common with chronic ACL injuries. But nonetheless, meniscus tears are the most common, and that's what we see the most in combination. And again, I don't want to go off on a tangent too much, but I like talking about this stuff. Sometimes they're missed on MRI too. So, we see them on MRI, but sometimes it's not until if we proceed with surgery that you find those tears.
Yeah,
So.
I would agree with that. I get a lot of clients asking about that situation. Well, they didn't see it on the MRI. I mean, we have to remember, and I tell them, you have a lot of artifacts like swelling, things can kind of hide it a little bit. So that's definitely something that you sometimes don't find until you're in there.
And if you want to tell your clients this, they should look up something called a ramp lesion, RAMP. So they're missed very commonly. You have to look in the back of the knee, and sometimes they don't need surgery, sometimes they do. There's other parameters which we go into a whole nother section about, but these ramp lesions, especially medially, are very commonly missed. And the ones that need to be fixed, but sometimes they don't always need to be. So people always say, well, how did you not know? Well, in my office, I tend to tell them that pretty much every patient is going to get a meniscus repair. And then if they don't, they're happy. And so that sort of reduces that risk. But I always tell them there's always a possibility. But I'd say it's about probably in my practice, maybe early on, it was maybe like 60-40. Now it's probably more like 50-50, but it just depends. But again, I do a lot of revisions too. So it's always hard to tell the exact numbers, but it's not as low as you think. When you hear a doctor says, I don't do any meniscus repairs, that could be concerning to you because a lot of patients need their meniscus fixed, even if it's 1 or 2 sutures.
As far as PT goes, what's an ideal situation for you? How soon, if they are a candidate for surgery, and we'll get into that talk in a second, if they are a candidate for surgery, what's the ideal recommended for you and your clients for prehab or PT before surgery?
So everybody pretty much gets PT before surgery. There's occasionally, I have some people that have saw a patient, yesterday that came in. She's 2 years from an injury. She didn't realize she had an ACL tear, which is surprising me, but that could be a COPR, which we could talk about. Mm-hmm. And so she's probably not going to need prehab just because she's got beautiful motion, perfect knee looking otherwise. The ones that come in stiff, like the 2 guys I saw today with acute injuries, they need prehab. So I like that sort of 4 to 6 window. There is a newer article from Rush that shows maybe the 7 to 11 week window is good. It depends, honestly, though. We like to say, you got to give it a certain amount of time, but it also depends on schedules. If you come in December, you're going to be waiting 6 to 8 weeks for surgery, and you go to an academic center, you're going to be waiting longer. But really, it's that 4 to 6 week window. Patients come in asking, like the guy today wanted to do it tomorrow. I said, it's not going to happen. Even if we could fit you in, it's not a good idea. Because as you know, the pre-injury range of motion is your post-injury range of motion. And so you always get concerned, there's facilities, which I'm not going to name, that are on different ski mountains that'll try to tell you to have ACL surgery within 24 hours because you got to do it before you leave the state to go back home. And the problem you have with that is people get a lot of arthrofibrosis, and you have probably seen that before. And so really, I don't pressure patients into ACL surgery. The only time I pressure patients into ACL surgery is with acute meniscus injuries, such as bucketed meniscus, meniscal root tears. Those need to be done, or a distal MCL. But otherwise, it's really that sort of up to 2-month timeline-ish. And in Seattle, as you know, it's a different timeline because is it before summer or is it after summer? Because really summer, no one wants surgery.
Yeah, that's definitely a thing here in Seattle. As far as, we talked about going through clinic with you, MRI, getting onto PT, things like that. They've got a diagnosed ACL, maybe even potential meniscus. One of the hot topic and discussions is graft choices and deciding who is a candidate for ACL surgery. You want to talk a little bit more on that?
Yes. So this is always a hot topic because there's a little bit of bias in this. And again, if you read enough articles, you can convince yourself that every graft is the best. So you just got to take that with a grain of salt. That being said, there is a lot of data out there about different graft choices, and we'll talk about, I'll give you my spiel that I give in the office for a primary ACL. So under 25, there's no doubt about it that we should do less and less hamstrings. Hamstrings are commonly done. It's the most common graft done. It's the most common graft done because it's the one we learn the most, but also it's technically the least challenging. And so when you have a least challenging surgery that works pretty well, people do it. The one caveat is that for patients, that they're females, younger, smaller, the graft sizes are smaller. And there's some data that shows if you can't get above an 8 millimeter graft, and a lot of times with a young female, you're not going to get that. There's a higher risk of re-tear, and especially in children. So that's one thing. So above 25, hamstrings reasonable, but the biggest complaint people get, and I don't do many hamstrings, so again, I might be biased, but again, I've changed my ways because of data. They get the weakness in their hamstrings, and it's not 100% recovery in strength. It's about a 90%. So it's still there. Now, men tend to be less likely to have that than women, but the number of complaints that I get for revision ACLs and people that said they never want to do a hamstring again is really frustrating. So I just reduce the numbers I do. Below 25, I don't want to get into too much detail because you're opening a can of worms with me when you ask me these questions. Below 15, usually quad. And people still do hamstring because of the growth plates. So I had a 13-year-old today. She was probably going to get a quad tendon with a growth plate sparing ACL. Above 15 to 25, I like to do patella tendon. And then patella tendon on request above that timeline. Patella tendon's awesome. You've seen it in every pro athlete. It's a very strong graft. It's bone fixation, which is nice because long-term, you don't have as many big tunnel widening. The caveat to that is about the 5% anterior knee pain rate. To be honest, in my practice, I didn't see that early on. We did a lot of patella tendons. When I first came out, I was doing probably 90% patella tendon. And where I trained and the big level, Penn, HSS, Rush, a lot of patella tendon. The problem you have is there's those people that get anterior knee pain, especially the exact same patient, the young female, that you want to watch out for. So I've reduced the numbers I do over 25 years old, but I still do them frequently above 25 if needed and if the patients understand all the risks and benefits. And then my new favorite, which is the quad. I love that. That's probably a majority now in my practice. And we take that partial thickness graft from the quad tendon. We've got videos on our website to take a look. And we can do something called an internal brace to the middle. So that's sort of my 25 and over. But again, I am a type of doctor that I told the patient today, I have a buffet of ACL options for you. I will do all of them. I can do a hamstring. I can do all these things. You choose what works best for you. And then this may be, this is always a hot topic for PTs and anybody, but the allograft discussion, usually 35, 40, I'll do an allograft. My allograft, I pre-select age category, and my allografts do really well. And again, from Rush data, we've seen that above 35, 40-ish, allografts do just as well. And it's a lot less pain involved. And especially as you get above 40, autografts are tough. And so my goal is to obviously give the best possible options. But if someone wants it on any edge category and they can convince me enough, then I'll do it for them. So that's fine.
What's we talk about, patellar tendon's gold standard, and the great thing about it is the bone plugs that you use. Is there any concern, if you do have someone of like the 30 to 40 age group that wants patellar tendon, do you take into consideration what their kneecap looks like? Because clearly, if you do take a little bit from the inferior pole, do you need to consider that? And at what point would you maybe say, maybe that's not the best option?
So if they have a lot of kneecap arthritis, which generally they don't when they're asking for patella tendon, but if they do, I would definitely avoid it. If they have preoperative anterior knee pain, I'm never doing a patella tendon on them. But the technique that I use, I don't go into the cartilage. I do an uppercut on the patella tendon. I think I have a video on my website. I did a head camera. So you can see I did the uppercut. That's what Brian Cole does too. And that really is nice because you don't dig too deep into the patella tendon. And sorry to gross the viewers out, but I like going through the details. So that tends to reduce that risk of damage. So Again, I lean away from it, but if patients want it, then I do it. Above 35, I mean, I just did a soccer coach that was like about 6 months ago that just demanded the patella tendon no matter what. I was like, I tried everything to convince her, but I'm not gonna have her go somewhere else just to, if I can do the graft, I do it easily. I do it all the time. So, we did it for her and she did great. It's all about, honestly though, I'll be honest with you, how patients do is up here. If I can do the same ACL, I'll do I can do any graft possible. They'd probably all do the same if the patients are really motivated. There's obviously data on different things, but really it's motivation. And I tell the patients, like, I'm going to give you my recommendation, but if you don't want the quad and you're 30 years old and you just want a patella tendon, like, I'll do what you want because you're going to do way better if you do what you want.
Yeah. I think the mentality part of it too. And I think at the end of the day, the rehab too.
Oh, that's the most essential. I keep forgetting, and you guys are really, it's not fair. I do an hour of 15 minutes of work and maybe 10 minutes of talking, considering how fast I talk. It's normally 20 probably, but the rehab is more important. I would say my job, everyone says you do so much work. I'll be honest with you. I do the hour and a half of work. You guys do like the 50 hours of work. So really the credit goes to you guys as well. And it's a team effort. That's why I'm friends with you guys. We work together really well, and because it's important. It's bad PT. If my patient has had bad PT, my surgery looks really bad. It doesn't matter how good a job I could do. I've done rocking surgeries that I walk out, I'm like, high five, awesome. Patient comes in at 6 weeks, super stiff, horrific PT. And it's a struggle the rest of the visits. And every visit they're telling me they're stiff. What'd you do, doc? It doesn't happen that often because thankfully nowadays I have my high profile PTs that I only send to. But a bad PT visit is a nightmare, and a good PT visit makes you look awesome.
Yeah. In terms of, new is the Bear procedure, the Bear implant. You want to talk a little bit about that?
Yes. So I just had my lady from Alaska flew in to look at her Bear. And so we've done probably like 10, 12 of these so far. This is the hottest topic. Everybody's talking about it on the internet. We just published a video technique that's got the internal brace to the middle. So people were freaking out about that video too. So basically what it means is the idea is that everyone wants the idea of saving your ACL, right? Like the problem is it's only for primaries and there's a certain niche group of people. So what we do is we fix the ACL back. And this is not a new topic of fixing the ACL. It's just that we've got newer techniques. And this has been studied for about 10 years at Harvard. And the data is really impressive because most of the data, if you may or may not know, is done at children's hospitals, and children are the highest risk of re-tear of the ACL. So the one thing, like a guy came today down from Everett to talk about a Bear, is that it is a little bit higher re-tear risk, but you save your ACL, and there's those proprioceptors that people think that are really good. And so what we're doing with this is we fix the ACL through certain techniques. We fix it to the wall, and then we slide in this collagen implant. It's a bovine collagen implant soaked in blood. And then what the idea is that basically you're turning a ACL tear into an MCL tear. And I think you guys heard from me at the beginning that MCLs almost never need surgery. So what's the reason? Well, the reason behind that is that the way the blood supply is there, they scar so much better. And so you've seen some second looks where these ACLs are like scarred and they have this beautiful sort of scar ligamentous attachment back to there. And so there are patients that candidates. The problem is FDA approval is only 50 days. So it's hard because patients get an ACL, they see some doctor doesn't do the Bear because not many people do. And this doctor will say, using ACL reconstruction. And they'll be like, well, maybe I need to have a repair. I want to see about this. So by the time they get in your office, they're like 40 days out. And so that's been the hardest part for me. And especially the out-of-state patients. We've had one patient from Idaho, we've had a patient flying from Alaska. It's a lot of coordination to get those things done. So that's probably the hardest part of the surgery. The technical aspect is not that hard if you do a lot of these and you're used to complex ACLs. It's really finding the right patient. And honestly, the hardest part, and I mentioned this at a previous talk I had, it's the discussion. Like if you start doing ACL repairs, you better prepare yourself for double the visit time because patients are confused and they didn't hear about this. So they come in asking for the Bear and they're not a candidate. You got to convince them another way. So it's just more time. But honestly, for me, it's an awesome opportunity to offer more options for the patients. And so the Bear has been good. So the re-tear rates we're seeing 7-8% re-tear rate, but you're saving your ACL and you're not doing any long-term damage. So if you do re-tear, I can easily do an ACL reconstruction. but I always consent someone for a backup ACL reconstruction because I don't want to do the surgery and not be able to fix them.
Yeah, I think in the research that I've read, seems like the ideal candidates like between the age of 18 and 35. And, it all depends on whether they had an isolated ACL tear or not. And have you done any bears without an isolated tear?
Yeah.
Yeah.
But you knew I was going to say that. So, I mean, I pushed the envelope. I mean, I just did a 50. So there's only like two of us initially that started doing it. So there was we had a lot of referrals that came in. And I've got a pretty extensive website on it. So we end up getting a lot of referrals for this. So that helps with sort of the patient population. So, I mean, I've done a 45-year-old, 50-year-old. I haven't pushed the envelope on the really young children. I get a little nervous on young children. It's just a re-tear on a young child is really challenging for me mentally. So I'm not ready to start doing. I had a 15-year-old ask for it, and I just wouldn't do it. I'm not there yet. 20s, 25s. So, when I'll do it in isolation most of the time. Meniscus repairs, yes, but not with multi-legs, no. So I had a guy that just came in 3 weeks ago, ACL, full MCL, posterior corner possible, meniscus bucketed, and he wanted the bear. I said, no, it's not a good candidate for it. Just because they also get increased stiffness because that protocol is slow. And the collagen implant in the front is a lot of stuff in there. And you already know that's the area where people get the most scar tissue. And so as a result, I'm sticking with the isolated ACLs for the most part, but doing some combinations. And what I'm doing with some patients, I'm actually adding an IT band tenodesis. There is not data on this yet, but we can talk about IT band in a bit about how it works. And I also, the little cheat to it on my bears, and I don't know if this is better or worse, is I do the internal brace. And so that internal brace there wasn't a technique for that. So we published that video just recently. And that's really, I think, has helped as well to give that sort of initial 3-month sort of thickness or rebarb to help people heal it. So my last 5 I've seen, they feel really good. Now I'm not getting repeat MRIs, but it's not fair. I'm in private practice. And so for every MRI I do, that patients have to pay for it. And so that's not feasible at this point. Mm-hmm. I don't feel right making them get an MRI to pay for it if it's not going to change my management.
Yeah, right. So as far as you mentioned IT band tenodesis, the LAT procedure, talk a little bit more about that.
Great. So this topic's interesting. I love it when people ask about it. So there's 2 ways. I think you had mentioned this before, but there's 2 ways to do this. Well, there's a number of different ways to skin this cat, but the idea is this. A while ago at HSS, they found there was another ligament called the ALL. And what it is a secondary ligament on the outside of your knee that attaches to your IT band attachment. And it's sort of a backup check ring. You may have heard of, if PTs are listening or doctors are listening, it's called a Sagoon fracture. And what it means is that little ligament's been avulsed. So it doesn't happen on everybody. But the thought process is, and we found out that if you add this backup check ring, it can significantly reduce your re-tear rate. And it's crazy that this used to happen a while ago. I had a patient, he came in, he's in his 40s. I did an IT band because he had failed his previous ACL. And his other side, he had an IT band done 25 years ago. So they were doing this for a while. It's just that it fell out of phase. And now what we've seen with all these amazing biomechanical studies is that by doing this, it is decreasing our ACL tears, because we want to make sure in kids, if you do an ACL, it's going to be almost a 12 to 15% re-tear risk. So how do we drop that number? Because 15% is not acceptable. Even 4% in a patient's not acceptable. If I have 4% of my ACLs and I'm doing 100 ACLs a year, that means 4 or 5 patients are coming back or 4 patients coming back and they're not happy. That feels bad to me. I feel terrible. And there's nothing I could have done. It's just a percentage. So can I drop that to 2 or 1? Or for all I do a ton of revisions, there's always a higher re-tear risk. Can I drop that percentage from a 12 to 15% or whatever you want to call the data? Again, it's all over the place, to a 6 or a 5. And so what we found with this is that these IT band or ALL reconstructions significantly reduce the re-tear risk. And it's crazy how hot this is right now. I now do it on every patient below the age of 18. There was another study that came out pediatric. Now, again, you've got to read the studies because most of these studies are comparing hamstring. And I already told you that hamstrings are a higher re-tear risk. And so what they did is they did hamstring. There's this guy, Alan Getgood, up in Canada, who's a phenomenal surgeon, phenomenal researcher. And what he found was if you add an ALL or an IT, he does IT, which is similar to what I do, or an LET to the surgery, you drop the rate of hamstrings to regular to patella tendon level. So they're basically dropping it significantly by doing this in all ages. And then they kept checking, they did the over 40, did the under 40, did the pediatric. And so what we do with this is we take a strip of the IT band, we place it underneath the LCL, and it basically recreates this ligament. But what's cool about it is there's been multiple data that shows it does not over constrain the knee, which is nice because you don't want to increase arthritis on that side. And secondly, it reduces that risk. And it's very easy to do. It takes about 15 minutes. There's no morbidity minus the small incisional scar. And so that's really the nice thing. And it doesn't over constrain the knee, especially if done properly. The ALL reconstruction is another way to do it. The data shows that the IT band works a little better, or the LET. So that's why most of us are starting to do just LET. Plus, adding another cadaver ligament to do an ALL is just not usually necessary. And so that's why I lean towards the IT band. And it's so efficient, but also I just did a high-level soccer player, and, I talked to her trainer and her agent, and they said, you have to do the IT. I was like, okay, fine. And so the only people that don't get it are my primary ACLs from like 18 to 45, 18 above, and all our revisions get it. And I think I was telling the patients and the kids that have to get it, because they're always, moms and dads are worried about the extra scars, especially in young females. I told them, I think in the next 5 years, everyone's going to be doing it.
Yeah. And I have it, and that scar looks awesome. I mean, you barely even see it. If anything, with the patellar tendon, like, you'll see that one a lot more than you do the LET. Yeah, LET is definitely up and coming. I would agree. It's definitely taken a little bit of a lag in terms of it stopped, and here we are again, which is pretty cool. And I think we need to do everything possible so people only have to go through this one time, because there's just way too many people having this happen more than once. Okay, so as far as protocol, we send you do your awesome work, you send them away. What's your typical protocol on something like an ACL reconstruction with or without meniscus, and with or without LET?
So with or without LET, I don't change. I have pretty much the same protocol. Now, again, it may be different for you guys when you actually get them in there, but I try not to restrict them at all with the LET. It's supposed to be an isometric ligament. When I do the LET, I check the range of motion, make sure it's still stable. I check to make sure medial lateral compartment look good. So for me, I don't really slow them down. On the meniscus, we do, and again, this is a gestalt. So I start off with a little more aggressive in terms of like making sure they're not weight bearing. But as you continue on in your practice and you get good results, you want to do less and less, because the caveat, again, like I told you before, is I see a lot of ACLs. I see a lot of second opinions, third, fourth opinions, and I see a lot of failed ACLs. And so I hear horror stories of like my doctor made me non-weight bearing for 6 weeks after meniscus repair. That's ridiculous. The problem you have is that, like, think about this, and you know this already. I'm trying to tell this to the viewers, not you. I know you're smart about this. So when you're loading your meniscus and you're walking, you actually push the meniscus out. Sorry, it's hard to show on here. And so as a result, that pushing out actually pushes it where we fix it. So the doctors are worried about tearing it, but really when you walk on, it's actually better for you. And so I tend to do 1 week of non-weight bearing, 1 week of partial, and my PAs keep yelling at me. They're like, why are you even doing that? You should just have everyone walk out of there. I'm like, well, I'm not ready to sort of push the envelope to the craziest level, but most of the time by 2 weeks, patients are walking pretty normally. I shoot for 6 weeks biking, 3 months sort of running-ish. Now, again, I let the PTs decide, because you guys are pretty aggressive on the way you want to do it. But it's also not fair for me to try to be too aggressive with that, because you guys are going to see them for 50 hours and I'm going to see them for like an hour total after surgery. And so I really kind of leave it up to you guys. Like, here are my guidelines, work through what you think. But, I'll have patients that are 4 months out that are doing pivoting, or 5 months out that are starting to pivoting, but they're not running yet. And so I let you guys decide on that parameter, because that's honestly, I'll say it here on the webinar, you're way better at that than me. I'm not going to make that final decision. It's not fair I don't see them well enough, and that's not my specialty. I'm a super specialist for certain things, and I leave my super specialists like you for the PT aspect of things.
Mm-hmm. Yeah, I think I tell everyone that I get on my caseload, the surgeon's protocol is a guide to tell us in the moment what we could do. So theoretically, someone could run at 3 months, but I'm going to make that decision criteria based and say, are you ready? And you might not be ready. And I find a lot of people most often are really ready by 4 to 5 months to start that journey. So, I mean, again, it all depends, but that's just an opportunity for us to do something, but doesn't necessarily mean it might happen at that point in time.
Well, the thing is, the PTs are like realistic and surgeons are fishermen. So, a fisherman says, I caught a fish this big. I caught a fish this big, but it was really this big. So I'll tell, all of us say, we do thousands of these, but you maybe do like 400. So it's like, we're really good. We have to be salesmen. You're going to see me and you're going to see 4 other surgeons. So you need to see. And the problem is all of us, unfortunately, have a little bit of ego and a little bit of confidence, which is good because you want that, especially if you're doing hard cases, because the last thing you want is a surgeon that's not confident going into your surgery. But that comes with the caveat of the fact that you got to be really careful by not over promising. But, I'll give an example today. I had 2 patients that came in that were adamant about getting back to every single sport possible. And I tell them, I don't think you're going to. And they still don't listen to you. And because they're so adamant about that. And you got to be careful because you don't want to tell them you're not getting back to anything like I see sometimes doctors do, because that's also a bad way. But it's sort of the goal. I tell people it's the Goldilocks method, where it's like, I'm going to let you get back as safe as possible. I want you to get back to sports. But at the same point, I don't want you to get hurt again. But also I have to realize I'm not going to stop you from doing crazy stuff after surgery. I can only tell you what I think is the best thing for you. But if I tell you not to do anything, they're never going to listen to
me. Yeah. Yeah, I think the best thing you can do is just advise the best you can, and the patient will do what they want with that information, which is hard sometimes, but it happens. As far as, we talked about returning to sport, what's your take on time before returning to sport after an ACL reconstruction?
This is a hot topic. This is probably the one that's the most challenging in the office because, my ACLs, for the most part, it's an amazing surgery to do. And there's a reason surgeons like doing these, because every visit's like high five, high five, high five, high five. They're getting ready. The patients are super excited. They're getting closer and closer. That first visit's hard because they're so far out from getting back. But then they get to the 7-month mark and they're not back. And they get back to the 9-month mark and they're like, why am I not back, doctor? All my friends said you should get back at 6 months because they read it on Google, and so that's the problem. And even if you tell them 10, 12 months, sometimes they don't listen to that. They want to get back Adrian Peterson style and come back and be better and stronger than they ever were. And so I tell them that I'm going to leave it to the PTs, and I am not a rigid surgeon. So I am not a 12 months or nothing option. I have had patients get back in 6 months. I've had patients get back in 8 months. I've had patients get back in a year, and I've had occasionally a patient get back in 14 or 16 months. It just depends on when they pass their tests. Those functional sports tests that you guys do as sort of super specialist physical therapists, especially your group that does so many ACLs, you have to pass the test before you go back. It's just like running. I'll tell you, like I said, I do lots of ACLs. So I saw 4 people in their ACL running phase, and one of them was bummed because they were 4 months out. They weren't running yet. Just because you don't run doesn't mean you're not going to get back to surgery. To get back to your pro sports. So it's just all about understanding different parameters, and each person's different. We want to make sure that we allow them to get back safely. But as we see in the professional athletes, everyone's so eager in that first year to get back, but they don't. And I tell this to the young kids I have, because that's the hardest part. They're so bummed they can't do their sports. They're a sophomore year or junior year, they're getting recruited. The first year you get back, you're just trying to be safe because that's the highest risk of re-tear. It's really that second year when you make the big jumps. If you see in the pro athletes, I'm a huge Giants fan. That's from not only taking care of the Giants, but also just my family's Giants fans overall. So Saquon Barkley, not so great his first year back. Second year back to crushing it. So it just takes time. And even these are pro athletes that have way more money than all of us combined on this call, anybody listening, and have way more resources. They have, even though you're an amazing P, they have 100 of you, to work with. And so as a result, they still can't get back at that level. So until it takes a while. So just be really patient with it. And that's an important thing.
Yeah. I like to just point out the stat of anybody who returns before that 9-month mark, just where the ACL is healed enough or matured enough to handle the demand of the sport. So 6 to 7 times greater risk of somebody who's returning before that 9-month mark. Doesn't mean you can't return to some sort of activity before that, right? Biking, running, all of those things, but high level activity, contact sport, minimum for sure. There's definitely a risk. I want to highlight too, you said everyone's different. Everyone's journey is going to be different for sure. mental setbacks, physical setbacks, and that might add to your timeline too. So, which can also be frustrating too. So as far as, you know, releasing someone, what exactly, you know, when they come to your office and say, okay, doc, like, I think this might be my last visit. When you're saying, okay, you're released to sport, what exactly are you looking for, or are you looking for from their PT, to make that decision?
I'm looking for functional sports testing. So I'm looking for you guys testing them, saying, you know, the standard's usually 90% of the non-operative extremity. But, you know, each group's a little different in terms of what they offer. Like I said before, it sounds like I'm pawning it off on you, but like a lot of docs are like 12 months, or they're like, I don't care what I want. No, I care a lot. I just don't want to make the final call because I'm not seeing them jump, pivot, shift. And like I see them for at those last few visits, like 1 2 minute visits. You know, I'll spend as much time as they want, but they're just like, they're ready to get out. Like the kid's like, I'm done with you. I don't want to talk to you anymore. You know? And so like, but with the PT, they have to be with you for an hour. Yeah. Right. And they have to be solidly focused and work on testing. And so like, I'll look at their quads, but I'm not going to measure the quad strength in the office. So that's what they need you guys for. And so I leave it up to the PT. So like the PTs can give me information, say, hey, they're 90%. I think they're ready to go. What do you think? Boom. Yeah. I'm totally game. Yeah. And that's really where it matters to me. I leave it in the hands of the PTs. The way it works, and you can talk to my staff, is I am the doctor that I do what I'm best at. But if I'm not the best at it, I'm going to make sure someone else does it. And so when you guys are the best at your jobs, I trust you explicitly, especially my pre-vetted ones. And thankfully, I've been around enough in Seattle, and I've done enough of these surgeries and had you take care of enough of my patients to know who the good ones are. And so I just have utmost confidence.
Yeah, I think team approach at the end of the day, for sure. I don't think it's one person's decision. I think it's the whole team as a whole, including the patient too. Okay, so we talked a little bit about setbacks in terms of extending how long they might have to go through their whole rehab process or just their ACL journey in general. Setbacks do happen, unfortunately. And, you know, there was a topic of manipulation, you know, when someone might need it, what you're looking for, and what your process is with all of that.
Yes, so this is everybody's favorite topic because you can hear us tout about all of our ACLs and how good our patients do and show you videos of them. But the way it works in life with surgery is if you don't have anybody that has a setback, you're not doing enough surgeries. It's just not the way it works. And so the biggest thing is I always tell the patients before they have surgery with me, I said, it's not, if you do 100% perfect, it doesn't matter how good your surgeon is. The issue is when you have a little setback, how do they react to that? And so that to me is more important because those are the patients you spend a little more time with. You try to titrate yourself. And that's when those are the ones that make you better, right? Like, how do I get better? What do I do differently? Or how do I adjust this? Because I'm constantly, you know, I'll have 6 ACL follow-ups, and each one I titrate myself a little different. I'm always ducking and dodging, trying to find the best way to get each person back. Some people hit with measurable dose pack at 6 weeks. Some people I'm more aggressive on the first 6-week appointment. So manipulations, I'm not frivolous with these, but I'm also not super lax. You know, I see a lot of second opinions for manipulations, to be surprising, after ACL. So like at 6 months, I'll get a call, this girl's not doing well or guy's not doing well. They're really stiff. They want to see you. And for me, those are easy visits because really I'm pretty aggressive. If they're really stiff at 3 to 4 months, I will consider doing a manipulation, but I never do isolated manipulations. That's the biggest problem. A lot of doctors just go in there and bend the knee as much as they can. Those do not do well. I scope the knee, clean out all the scar tissue, and then I gently bend the knee. There's no risks there. There's very little. I've never had an infection or major injuries. And I know this on the recording is going to be a problem because people are going to hear this. But most of the time when I do that, they're actually jump really fast back in, and they're actually better than they were. And they basically miss like 1 or 2 weeks. That's it. And most of the patients are some of my best patients after I do this. And so if you need it, it's a scary thing to think about a second surgery, but if needed, do the right thing. So, and a lot of times I'll scare you. I'll be like, at 6 weeks, I'll be like, you don't get better. You're getting a manipulation and a scope. 3 months, I'm like, this is about it. And then maybe 4 months, I'll pull the trigger. But I've done it at 3 months. I've done it at 6 months. I've done it at 9 months. I don't wait too long though, because patients also get really frustrated. And you don't want to break that mental status. That's extremely important. So I have 2 or 3 people I can think of that I had to do this on over the last year. They're some of my happiest patients now, but it just took a little while. But it's never easy for me to come in the room and go, yeah, you know, I did my best if I could at your surgery. I know you wanted me to be perfect, but it's not perfect. I need to go do this again. I need to go do a manipulation and do a scar tissue cleanup. And they're never happy. But as soon as they do it, it's that huge smile on their face. So that's worth it.
How often do you get, I mean, it happens, it's probably maybe rare, but how often do you have to do more than one manipulation throughout someone's journey? Mm-hmm.
But that's the problem. The thing is, you keep, and I'm not correcting you, but you keep saying manipulation. So
Yeah.
doctors love the word manipulation because there's some docs who just keep manipulating the person's knee. That is not what you're supposed to do. It's
So
the
like,
easier thing to do, but it's also harder to do. It's harder to do a scope with scar tissue. When you get into a scope with scar tissue, sometimes you can't see anything. It's like a snowstorm in there.
mm-hmm.
And so you got to know what you're doing. I mean, I've had two or three I could think of, and they were friends, like friends that got referred to me. And you go in there, you can't see anything. One of them was a doctor. I'm like, oh my gosh, this is not. And he was like 4 years out from his surgery, he just didn't feel right. So, you have to be prepared. But if you know what you're doing, you can be efficient. It takes me like 20 minutes, 30 minutes to do. But the biggest thing is like you have to do the scope. You have to clean the scar tissue out. And then you're not going really aggressively during the manipulation. It's a very easy manipulation. Usually once I do that, I'm usually able to get to like 120, 125 degrees, and I'll get you that extra 10 from the manipulation itself. And so that's the big thing. But once I do that scope, I have not had to go back in and do another one.
Mm-hmm. So is your typical, the typical plan protocol you have in place, someone calls between the 6 to 8 week mark or within that first couple months, complaining of stiffness, not getting their range of motion, not hitting that, are you going to, clearly you assess the situation, but do you often just prescribe the Medrol pack from here on out? Yeah.
Yes. I start with one. I used to do cortisones. I stopped doing that. That does not work. Like the cortisone injection, you're trying to go through scar. Nobody likes that injection. And it's been super useless. So what I do is so 6 weeks, so the way it works, let's say you're my patient. Okay. That's probably the easiest one. 6 weeks, you're stiff. So then I scare you. I say, if you don't get faster, I'm going to manipulate you and do a surgery. And that sounds bad, but it really is a very effective motivational thing. And then let's say that's 5% of the patients. Then it's like 2% are left at 3 months because they're terrified. They don't want to have that. And then their emotion's way better. And that works really well. And I avoided a surgery. And then you're down to 1%. And then by 4 to 5 months, there's maybe like, let's say I do 70, 80 ACLs. There's maybe two that need to have the actual surgery. And so that's when I pull that trigger. So I'll do the Medrol dose pack. Every once in a while, I'll get a second Medrol dose pack, especially if they get past like 90 to 110 degrees, I'll let it go. But I will tell those people, and I know we talked about this before the call, that they will have a slower recovery no matter what. And so it's going to be the solid year for them if they get that acute thing. But the good news is, and there's been, I can't remember, maybe a year ago, a study came out that they actually heal faster. And so that's a positive. They have a much lower re-tear rate.
Mm-hmm.
And the hard part though is it's hard to get a good lockdown on them because they're so solid, but they tend to heal a lot. I have not had a person with arthrofibrosis re-tear their ACL.
Yeah. Sometimes it pays off to be stiff.
Yes.
So in terms of, we talk about some setbacks, there is cyclops lesion too. Do you see very many cyclops?
I thankfully don't. Maybe I've had two in my practice. The way I do my ACLs is I take out, and I was taught this, I take out enough fat pad that I can see the patella when I'm doing the surgery. And I think that helps. And if I ever see like any piece of tissue moving around, I'll remove it. So I have had not many cyclops. I have had arthrofibrosis. I probably get maybe two or three a year, and then maybe 2 or 3 second opinions for it. So I do it. So I'm not above that, but I have had very few cyclops. I have no idea if my technique is the reason it doesn't happen, or I just happen to get lucky.
Mm-hmm.
But nonetheless, I have seen very few. But when you get it, it's always something you look for. That clunk, clunk, clunk. I think the problem is the word clunk is associated with cyclops, but it just could be a big piece of scar tissue in the front and not the actual cyclops lesion. And so those patients do improve. I just never do surgery for the word clunk. But occasionally I'll do surgery if they're stiff and they have like some anterior knee issues, and that's still pretty effective to do scar tissue release.
As far as, going back to your rehab protocol, I've had a few community members ask about the controversial topic about leg extensions. What is your opinion on them? And if you're good with them, at what point do you recommend your clients, or are you okay with them starting it?
I mean, leg extensions are always a hot topic. Everyone wants to know about when's the right way to do it or not. You know, I I tend to be okay at like that 6 week mark, if not a little bit later. It just depends on the person. I, I, Nowadays, with our techniques, our fixation techniques and our graft techniques, and again, I usually use a quad or I'm using a patella tendon, so they're almost 10 millimeters. I'm not super worried about the stretching the graft. And to be honest with you, I've had patients that have not followed the protocols very well, or PTs that have gone rogue. Not you, you're awesome, but PTs that have gone rogue and they still do pretty well. So I'm not super worried as much about that part in particular. But I know, again, if you want to go to the nitty gritty, you don't want to put a lot of stress on the graft. But usually 6 weeks or so, I'm happy with it. Now, an allograft, I'd be a little more concerned because they take a little longer to integrate, even though the recovery timeline's the same. So maybe more like 8 to 10 weeks. But I tend to not do too much restriction. I let the sort of PTs ride it out.
Yeah. Yeah, I tell everyone too, it just depends on the situation and what kind of graft they had and how we can really stress it or not. Yeah. That's all the questions I had. Is there anything else that you'd like to add that you feel like is a common question that you get on your end? I don't see anything in the chat right now, but if there's anything else before we are finished.
I mean, we could go on and on, but basically, I tell people this, the one thing I get, and I know you're not as much of the discussion topic, but I know we talked about copers and non-copers.
Yeah.
It's the hardest part, I think, for people is, PT see me and the patient comes in, they need ACL surgery. ACL, they get an ACL reconstruction. I tend to see pretty much no copers because coper who can cope without an ACL doesn't come into my office, right? But there's something to understand that if you have an ACL tear, there is so much data to show that you should strongly get it reconstructed. And I worry about the word coping being a misnomer because as you know, my practice consists of meniscus and cartilage transplants, and those are generally patients that didn't have their ACL done. And so those are sort of a little bigger animals once you start getting that. So there are people that can cope as you get older, but we've seen, and I'll tell you right now, the data is again shifting the same way with kneecap dislocations, shoulder dislocations, you name it. If you're missing something your body was given, you should strongly consider getting it put back in or fixed. And because you do not want to have the other issues long term. Now, again, maybe you're sedentary, maybe it doesn't matter that much, but that's not the way Seattle works. Everyone's a climber or a runner or a pivoter or a jumper, you name it. And so my whole goal is to prevent I love doing the multiple unusual cartilage transplant meniscus surgeries. You know that. But if I can save everybody's knee and prevent them from ever having to go through that process, that is not a fun process. And so I really hope that those people at least seek out somebody to ask for advice, and at least see anybody in the area that they trust and understand, that'll give them this information. But understanding that, the word coping really should be taken with a grain of salt.
Yeah, I think the important thing too is in making your decision on what you're going to do surgically, a lot of people are just trying to figure out what they're dealing with, and a lot of psychological stuff plays in. There's good evidence behind waiting that 6 to 8 week mark and doing prehab and maybe getting to a point where you can cope, right? And that's going to help you on the other side of the surgical procedure, and getting there, accepting the whole situation. Would you ever consider, if someone walks into your office, the hot topic lately is, non-operative approach. You mentioned sedentary, someone who just does very basic stuff, doesn't do any high level cutting, any of that stuff. Would you ever say, yeah, sure, just go do rehab, get all ready and get back to lifting in the gym or something?
I might. I'm severely biased, like I told you before. So I'm going to tell everybody I'm severely biased as I see so many non-copers and I get to see all the disasters. I don't want to say the word disaster, but, girl came in today, meniscus removed, cartilage hole, second ACL, first ACL not done well. Patient today again, 2 years. I saw a girl today super active, no ACL for 2 years. Meniscus is torn up now. I really have trouble recommending doing no surgery for active patients. There are probably people that can get away with it. And again, I don't think those people show up to the surgeon because they know that they're going to get offered a surgery. And so maybe there is definitely a bias there. There's probably occasionally someone I could think of if they're like, I don't want to ever do, because I tell patients, like, if you don't want to, I don't do the surgery so you can walk. right? That's not, ACL is not a walking surgery. It's a sport pivoting surgery. So I am pre-selected and screened for this number of patients in this triangle. The bottom ones that don't want to do anything, they're usually not coming in. So rarely in my office am I recommending it. I can maybe think of maybe a few off the top of my hand. But I'm sure there are people out there. I don't want to poo-poo the idea of full coping. I think the coping word that you used is important. It's not coping whether you can cope without an ACL, is can you cope with your surgery and cope with what's necessary to get you back to your best possible evaluation. And that's where the PT and the surgeon together can work together to give you the best possible outcome.
Mhm. What is your partial ACL tear? What is your?
That's good. That's a really good one. Yeah, we have one of these today. We had talked about it. So basically, these are caveats. So like partial ACL read on the MRI, or someone feels unstable, you feel it, it feels like it's a partial ACL, but they're not fully torn. I never jump to surgery right away with those. Occasionally, I can give you one example. So I had a kid, bucketed meniscus, stuck, partial ACL. So the two options were do nothing with the ACL and fix the meniscus, or fix his ACL, which is another topic we talk about another time, where we tighten up his ACL a little bit, low risk, no delay in his recovery, and then fix his meniscus. That's what I did, just to get that backup check ring. But for the most part, in these partial ACLs, I will rehab the heck out of them. And those are the copers I think you're talking about. Now, those probably 10, 15% get surgery, but I let them try not to have surgery if possible. And if I don't see that pivot shift on the MRI, I'm definitely trying to let them cope as much as possible. But I tell them, I always do this. I do initial injury, feel their ACL, feels kind of loose. Let's see you back in 2 months, PT. If I come back in 2 months and they say, I feel awesome, doc, leave them alone.
No.
Remember, I'm doing surgery a lot of times for the subjective things. I tell patients, I do not treat MRIs. If I treated MRIs, I wouldn't have time for this webinar. I would be operating still, because I would just be operating on everybody that shows up in the area. But instead, I operate on when you tell me you have a problem. So there's a lot of these people that say I have instability, I feel unstable. They've never had a tear of their ACL, but they know what that word is. And so that's immediately to someone that's probably going to get surgery. And so that's really what I look for. So if they feel unstable after 2 to 3 months of surgeries, then I'll do the ACL reconstruction. But I let them dictate that. Again, I told you, I'm the buffet surgeon. You choose what you want to do. I'm not going to pressure someone with an ACL sprain until they're ready.
Yeah, yeah. I've rehabbed a lot of partials, and it's not until if somebody experiences that rotational instability, then that's our answer. Okay, go see Dr. Garcia or whomever it is to get that fixed. Okay, I think that's everything.
Awesome.
Yeah, thank you for joining us today and taking your time out of your day. And we're happy to get together for some more Q&A next time, and we'll dig a little bit deeper into some other topics too.
Awesome. Well, thank you for having me. Highly recommend you guys. You're awesome. I love your social media. And, everybody is really, really, really thankful for having me on here. This has really been fun.
Yeah. All right. You take care.
Take care.